I have the kind of great joy of introducing Dr. Roxana Daneshjou from Stanford University to talk with us today. Roxana is a dermatologist and an MD PhD. So she did her undergraduate at Rice University. Going back, I know Roxana both from high school as well as undergrad. And we had the opportunity also we were at the same place for postdoc, residency, and fellowship. Roxana did her MD and PhD at Stanford, worked in Russ Altman's lab, and is currently a postdoc in James Zhao's lab. She's done a tremendous amount of work in dermatology, AI, and applications of AI to dermatology, as well as has multiple grants from various places at Stanford, including Spark, including the Catalyst, including collaborations across other institutions, really focused on how to implement essentially AI in dermatology. So I want to make sure that she has all the time to present the stuff that she wants to do, but we're really excited for you to come talk with us, Roxana.
Thanks so much for inviting me. I hope we get a chance to discuss further at the end. These Zoom conversations are kind of interesting because you don't get as much feedback from the audience as you were talking. So today I wanted to talk about artificial intelligence in dermatology, both the opportunities and some pitfalls. And then these are my conflicts of interest. So as David mentioned, I am a practicing dermatologist, and I initially came from a genomics and bioinformatics background. But as I was finishing up medical school and starting my residency, I became really interested in artificial intelligence and machine learning tools. And that was kind of spurred by the research activity that was happening at the time. And there have been this flurry of headlines that I saw: man against machine, is AI better than dermatologists at diagnosing skin cancer? And Google saying in 2019 that its AI detects 26 skin conditions as accurately as dermatologists. And just question of will there be an AI doctor replacing dermatologists? So I saw these conversations happening in dermatology, and I wanted to dig in deeper, especially coming from sort of a computational background, knowing that sometimes what you see in the media is a little bit more sensationalist than what the actual truth is. And one thing that, and I wanted to also add that there was this position statement from the American Academy of Dermatology basically saying that, they accept AI, but they want to see AI working synergistically with humans to improve our capabilities, this idea of augmented intelligence, with synergistic working together rather than replacement of physicians, a concept that I'm sure many people in this group agree with, that we can use these tools to improve our workflows and to do better. Now, one thing that struck me immediately as I saw these flurry of headlines, and this actually draws from coming in genomics. So in genomics, we were having this reckoning at that time with equity, because most genome-wide association studies were in European ancestry individuals and left out diverse populations. And as I was beginning to read the machine learning papers that were coming out in dermatology, I noticed that there was a lot of opportunity for bias. And in fact, subsequently, there has been sort of this realization that there are a lot of chances for bias to set in with these algorithms, either with lack of skin tone representation or noisy labeling or other ways that bias can creep in. And actually, some of these headlines are very recent as say 2 weeks ago, saying, for instance, Google's new dermatology app wasn't designed for people with darker skin, because the initial paper that they wrote describing their algorithm had less than 3% of the 2 darkest skin tones represented in the training and testing data. So sort of the first half of this talk will be diving into, where do the biases come in, and what should we be doing to kind of build the foundations for fair and equitable dermatology AI. And then in the second half, I'll talk about some of the work we've done with building algorithms with those tenets and principles in mind. And so opportunities for bias exist at every stage of algorithmic development. It has to do with the problem selection. So for example, in dermatology, most of the problems that people select to look at are diagnosing cutaneous malignancies and not so much looking at pigmentary disorders, which are the things that more often affect skin of color. Data collection is actually what I'll be focusing the most on. But I did just want to recognize that the data is not the only place that the bias can creep in. It's just, if we wanted to talk about all of these different things, we would be here for many, many hours. So other domains where bias can creep in is, how you define your outcomes, and whether some of the disparities that already exist in the healthcare system get baked into your algorithm, how you actually develop the algorithm, what kind of questions you ask, and how you look at it post development. So when it comes to data, what happens, and so I have this sort of structure of how I think about building clinical AI algorithms, right? You put in some training data and test data. Usually these are retrospective, and you build this model, and then you start doing some clinical testing, you deploy it, collect some prospective data, assess model impact, and decide whether or not you are happy with the real world application of your model. But the issue is, if you have biased data go in, you basically get a biased model that comes out. And so a few examples of bias in dermatology AI data sets are noisy labels, lack of representation, and technical issues around photography. So some of these issues are generalizable to other domains outside of dermatology. I'm sure you guys have a lot of conversations in cardiology, radiology about how you label data. Representation also may be an issue in other domains, but is particularly striking in dermatology since skin tone can affect how well the algorithm trains to recognize something. And then we in dermatology, as we do not have DICOM standards for our image acquisition, because it's photography, though there are people working on that, have to worry also about some technical issues around photography. So we were actually interested in quantifying the sources of bias in dermatology data sets and published papers. So we looked at papers at the intersection of AI and dermatology just to get a sense of where the field is, like what's going on, what are people reporting, what kind of data sets are people using, what kind of flaws might exist in those data sets, and to be able to say to the community, hey, these are some of the issues that we need to be aware of. And so 70 papers met criteria for this. And one thing that we saw, which is probably not going to be surprising to anyone in this group, is that most of the papers were built off of private data sets that were siloed in their institution or with that group, and there wasn't much data sharing. And so most of the papers that we looked at came with these one-off data sets. Now, there were data sets that were publicly shared, and the one labeled 1, which has the most papers, I believe it has 28 papers around it, is from the International Skin Collaborative, the ISIC group, which is a public data set. And we also want to sort of demonstrate, again, also the value of public data sets because they help generate papers. It's easier to look at the data sets and to assess whether or not there's any bias. But in our field, as is the case in most AI and medicine fields, most of the data sets were siloed, private, not shared, and we're not really able to assess what's in that data. So we have to go purely off of what's reported in the paper in order to assess bias. And so that comes to an issue of transparency. So there are many different kinds of tasks that people can do with AI in dermatology. Many people really like the can I identify skin cancer task. So if I get an image of a lesion, is this a melanoma, squamous cell, or is it a benign lesion like a nevus? But we found that only 36 of the 56 papers that we assessed used the gold standard of pathological diagnosis for the label of the skin cancer. And one of the papers that doesn't use pathological diagnosis for labeling their melanomas, their squamous cell cancers, and their basal cell cancers is actually the paper that was written by Liu et al. From the Google team, which was the foundation of the DermAssist, a tool which they have announced they're planning to release in Europe at the end of the year directly to patients, for patients to make an assessment of whether or not their lesion is skin cancer. So they're going to put this tool directly in patient hands. Now, why does this matter? You would say, okay, but dermatologists must be pretty good at like looking at something and labeling it as skin cancer or not. Well, actually, that turns out not to be completely true. So for melanoma, for example, the numbers vary, but on average, a dermatologist biopsies 7 lesions that they suspect could be melanoma before they find one true melanoma. And so unfortunately, that means that if your label is based only on expert consensus of looking at a picture and not pathology, there could be many lesions that you're labeling as malignancies that actually aren't malignancies, or you'll be missing malignancies in general. And every dermatologist, including myself, have horror stories of going in and biopsying something and saying, oh, that really doesn't look like anything, but I'll take a sample and it actually comes back surprisingly as a melanoma or as a small squamous cell, and you get surprised, or a Merkel cell even. So I think that this is why labeling definitely does matter, and something that we're trying to establish as something to be wary of when you're looking at data, how the labeling was done. And then the other issue is we've talked about representation and making sure that all skin tones are represented. However, it seems like probably most data sets are actually not representative. So in ethnicity and skin tone are obviously not the same thing, because we have a variety of skin tones across one ethnic group, but only 14 of the 70 papers even described anything about the ethnic group of the patient population used. The rest had no descriptors. So basically, it's a black box. And only 7 out of the 70 described any metric of looking at skin tone. And in fact, over half of those 7 described that they didn't even include darker skin tones. So, and then the rest, of course, we just don't have that information. But given sort of what we know the other data sets look like, they are unlikely to be more representative than the ones that we have access to. So those are some of the issues that we saw within the data sets. And now there are some other issues that we deal with as well in terms of technical photography, as I mentioned. So let's say you want to design a data set in good faith. You want to make sure it's representative, that includes skin tones across the spectrum. And so you go about doing that. What are some of the other issues that we face? So when it comes to photography, historically, color balancing has actually favored skin of color. So when Kodak developed, on these other major companies developed their sort of color balancing standards, it was around light-skinned models. And actually, these cards were named after those models. So they're called Shirley cards. And so basically, for decades, whenever you did any sort of film photography and went to do the color balancing afterwards, it was centered against white skin. And so darker skin tones, the color was not an accurate representation of the actual individual skin tone. Now, we have digital cameras. So that means that things have improved, but there are still differences in the color balancing algorithms between the digital cameras. And while I haven't seen any quantified research studies looking at this, you just have to pop over to YouTube to see individuals taking photos of themselves with an Android phone, iPhone, different phones, and then kind of displaying how their skin looks different across those phones, particularly for darker skin types. And of course, there's always going to be some discordance between real life and color capture. And dermatology color does matter because we look at erythema, redness, purple, and how those colors appear on the skin to kind of try to decide whether something's inflammatory, neoplastic, how active it is, whether it's been partially treated. So for us, capturing accurate color and doing good photography is incredibly important for us to be able to do our work. And the other unfortunate thing is that photographic practices in clinic have also been very much centered on lighter skin tones. And so I was actually involved with Dr. Jenna Lester in putting this piece together, looking at what are the best practices for capturing cutaneous disease on darker skin tones. And one of the major takeaways is you never want to use the flash. And we see this all the time in the photos that we're trying to use for our algorithms. They've been taken with flash photography on darker skin, and you see the flash artifact, and the color just doesn't look accurate. And in fact, the flash artifact many times can sort of cover up the lesion so that you can't quite make out what's going on. So those are some of the issues that we've noted. It's not comprehensive. There are many other things that we have to deal with in dermatology when we're building these algorithms, many other sources of bias. But I wanted to take a moment and just, I guess, are there any questions for the first part? Because these are sort of in parts. So I'll go ahead and take any if anyone has any questions there, and then I'll shift gears. If we're good, we're good. All right, so first half, we talked about some of the issues that we have at a foundational level dealing with building up these algorithms, biases in these algorithms. And of course, I hear all the time, the regulatory bodies are going to protect us from the biased algorithms. And actually, this is some work that I did with David. So we were looking at FDA-approved medical AI. And I have to say, as a dermatologist, none of them are in dermatology. So this is all about other applications of AI in medicine. Now, there have been some companies who have said that they are going to be applying for medical AI approval. And there have been companies who have applied for CE mark in Europe, but we were purely assessing the FDA and FDA and medical devices in the US. So 130 devices that have been approved in other domains. And unsurprisingly, 75% of the applications have come in the last 2 years. And I expect over the next couple of years that there's going to be a deluge of additional applications. So we found that 126 out of 130 devices, they only used retrospective data to test the devices. And out of 54 high-risk devices, by high risk, we mean AI algorithms that if they fail could cause patient death or high morbidity, all of them used retrospective data only. And if we sort of hark back to what I mentioned before, in my mind, the model of AI development is you build something based off of retrospective data, then you do some clinical testing in a prospective manner in order to check anything that you may have missed in the retrospective setting. The other issue is 93 of the 130 devices don't report how many sites they test at. And this is actually an issue because single site testing means that that algorithm, when it's moved to a different site, may no longer behave in the way that you think that it should behave. And so we sort of did this demonstration using pneumothorax X-ray data sets where we trained off of a data set that was off a single site, and then we tested at a different site to show drop-offs in performance. So of course, and of course there's a held out test set from each group. And so when you train on Stanford pneumothorax X-rays and you test on Stanford pneumothorax X-rays, you have reasonably good performance. But then when you take that same algorithm that's been tested only on the Stanford, that's only been trained on the Stanford data, and you test it at, say, the NIH or a different site, you have drop-offs in that performance. And so when we look at sort of what the data the FDA gets, when they get performance data that's only for a single site, they are not sure. They have no quantification of what happens when you move to a different site, where the data might be slightly out of distribution because of differences in imaging technologies or differences in patient demographics or different, sometimes you can't exactly tell why there might be differences between the different sites. That's like an area of ongoing research. And of course, this is with X-ray imaging, which is of course a little bit more standardized than the photography we do in dermatology. And you may not be familiar with how photography is done, but basically it's usually just like me on my iPhone taking a photo, or a nurse with whatever phone they have. And so I might be using an iPhone, 10, somebody might be using an iPhone 6. People may have Android phones. Other clinics might use a DSLR camera. And so we're talking about data that's even less standardized than this imaging data that we have here. And so we anticipate that this same issue, it is going to be significant within dermatology as well. And so some lessons to keep in mind is that basically data transparency is important. And so if you can publicly release any data, and I know David's been great about doing this with the echo data, that is incredible. I know there's patient privacy issues, but there's no better way to be able to interrogate where biases might be in the data or where things might fall out of distribution than to be able to actually have access to that data. Data sets need to be cleanly labeled. So as I mentioned in dermatology, one of the things that we look at is, labeling skin cancers without having confirmation can lead to incredibly noisy labeling. We need data sets that are representative, particularly in dermatology. This is an issue because skin disease looks different across different skin tones. And then for us, it's very important to think about technical issues around photography, taking good photos, and making sure that that's not something that is going to be an issue. And then, of course, the importance of pulling data from multiple sites so that you can make sure that you don't have something that's out of distribution when you move sites, and so that you can kind of train out the idiosyncrasies that come up between different sites. And of course, as I mentioned, it's not always obvious when data is out of distribution. That's part of the reason we need multi-site training and testing. And part of the reason I think prospective clinical trials are also important in order to actually make sure that the algorithm is doing what you think it's doing. So I'm going to shift gears now to talk about opportunities I see for AI in dermatology. So I mentioned there's all these, different technical kinks which we're still working out. And I think there are things that we're going to be able to surmount, and certainly things that we're just trying to be cognizant of as we design these algorithms. And I firmly believe that AI is going to absolutely change and revolutionize both the practice of medicine, but also how we do things in dermatology. And I'm going to talk in detail about two different projects that we've done to try to impact change in our field. The first one will be about using AI to quantify bias in dermatology educational materials. And the second will be about using AI to help assess image quality in teledermatology. So among dermatologists, there has been a reckoning over the fact that our educational materials have a significant underrepresentation of skin of color. And there has been a flurry of research papers where people have sat down, gone through our general textbooks, gone through lectures, gone through research papers, and basically quantified and found that there was just a very significant underrepresentation. And since there are probably not many dermatologists in this audience, I just wanted to do a sort of a basic primer on skin types, skin tones. So this is the Fitzpatrick scale. It's the most commonly used clinical scale for how we assess skin tone. It was originally designed to be around how easily you burned in the sun versus tanned. So really that's the way the scale was intended to be used. It's sort of shifted away from that, and now people are using it to basically like look at skin tone, eye color, hair color, and assign people to a spot on the scale from 1 through 6. I will mention the scale is quite flawed. It was originally, when it was originally designed, it actually left out the darker skin tones. Those were added on later, and it doesn't fully capture the diversity. Like the scale is kind of small for the actual diversity of skin tones we see. And so there's been a lot of conversation around, do we change the scale? Do we choose something that's actually more representative? But as for now, this is the scale that everyone is using. And as I mentioned before, there have been several research studies that have come out looking at the distribution of skin tones across our educational materials in dermatology. And all of those have harnessed the power and will of wonderful medical students who have sat down and done this labeling by hand. That one paper that I had shown from the JAD, I actually know the authors very well. It took over 100 man hours to label the images within those textbooks. Now, as I had mentioned, the Fitzpatrick scale is not a perfect scale. And so there are other scales that are not used in the clinical realm, but have been used in the research realm to try to quantify pigment or skin tone. And one of these is the individual topology angle. Individual topology angle looks at the blue, yellow, and the luminescence of the pixels. And it turns out that that combination actually corresponds really well to the amount of melanin seen in the skin. And so this is a scale that's used sort of in research, and particularly when you want to quantify skin tone in images, not by a clinician. And so working with a team at IBM, we've asked, can we basically take what's been done in the research realm with trying to quantify bias in all these educational materials and basically automate it so that it doesn't take many hours to do it, and so that you could actually assess it in real time as new research papers come out, as people put lectures together, as people put textbooks together. And so you don't have some poor medical students sitting there for hundreds of hours just looking at images and tabulating, what the skin tone is. And so using basically a proprietary corpus extraction service that IBM has developed, we were able to extract the images from the textbooks. And once we pull those images out, we built a model that basically uses an RCNN to segment out the healthy skin in the image, and then look at the pixels in the healthy skin and compute the individual topology angle, which, as I mentioned, looks at both like the pixel luminescence and the blue yellow pigment. Now, if it were up to me, I would say we could do everything by ITA, but that's not really how the clinicians have been looking at this. And so we actually do end up mapping back to the imperfect Fitzpatrick index. And then from there, we generate sort of a distribution of the skin tones in whatever corpus that we have given it. And so we looked at skin tone prediction in 93 images, which I labeled from 1 through 6. Now, between any two dermatologists, 1 and 2 or 2 and 3 and 3 and 4 are actually like pretty close to each other. Sometimes in grand rounds, people get into kind of half joking arguments about whether someone is actually skin tone 3 or skin tone 4. And so when we look at this confusion matrix, we see that for the most part, the confusion is the skin tone next to it, which is not surprising because even among humans, there can be disagreement of what the skin tone is. Really, what we care about more is that binary of lighter skin tones versus darker skin tones to make sure that there's representation of the darker skin tones within whatever educational materials. And so actually when we recapitulated the task that was done by hand by the medical students. We took those same exact textbooks that they had assessed, and we said, all right, we're going to assess this with the algorithm. And we found that we were within 6 percentage points of what the medical students had hand labeled across thousands of images. But instead of having to take hours to do it, you could assess this basically in minutes and be able to show that, yes, you do have an issue in these textbooks where darker skin tones are significantly underrepresented. And so then we sort of looked at, let's just like assess the distribution across all 6 skin tones in these textbooks. We don't have a good ground truth for this because essentially nobody has gone through and tried to label, the photos for skin tones 1 through 6. That would just take even longer than trying to do a binary task. But what we find seems pretty congruent with the binary task. And so once again, we see that the darker skin tones are underrepresented in these educational texts. And so what are the future applications of this tool? I've actually been talking with people at the American Academy of Dermatology about, can we do something where we use this tool to sort of automatically assess lecture materials to make sure that we have representation when we're doing teaching sessions through the academy or through different institutions. And we can try, and the other thing that we want to try to use this for is for catching bias in real time. So when the COVID-19 pandemic hit, several months into the pandemic, Dr. Jenna Lester published this paper basically being like, oh, I went by hand and looked through all the photos of COVID cutaneous findings and found that almost all the photos are on lighter skin tones. There's no photos of these cutaneous COVID findings in darker skin tones. And so part of the reason it took months for this issue to be caught is because somebody had to sit down and spend many hours digging through all of these publications and assessing these photos. But if we had ways of doing it automatically, we're hoping that we can flag some of these issues, and hopefully we're not going to have another pandemic. But whenever we generate both research findings, educational materials, we just want to make sure that it's representative so that dermatologists can identify disease across all skin tones. So that was one application, which I'm very excited about. Development is ongoing. We're hoping to actually release an open source version of the tool by the end of the summer so that we can put it in the hands of dermatologists and educators. And then the other project, I just want to say that big thank you to the IBM team that we work with. It's truly a global team, so it's always fun trying to figure out what time to meet for our meetings to make sure that we capture everybody in the group. So I'm sure most people these days have some project going on with COVID-19. And like everybody else, the same thing kind of happened to me. I was working on the research that I've described before when the pandemic hit. And I don't know what happened with the rest of medicine, but basically for dermatologists, we went from seeing patients in person all the time to a period of several months actually at Stanford where everybody was 100% telemedicine. And so for us, there was a 50x increase in digital visits. There were people who were doing some digital visits here and there, but huge increase in digital visits for dermatologists. And the thing about dermatology is that we can't actually use the video to assess your lesion because the video quality is just not good enough. So we have to ask patients to send photos ahead of time for us to assess the lesion. And one thing all of us quickly learned is that even with detailed instructions, many patient photos for telemedicine are very poor quality. And this photo here is not a real patient photo, but every time I show this to a group of dermatologists, people laugh because they know that this photo that I'm showing is not an exaggeration. People actually send photos, and there's like a lesion here, right? People actually send us photos that look exactly like this. A large proportion of people send us photos that look exactly like this. And what that means is that we have to manually review these photos prior to the physician encounter and then call the patient up and ask them to send another photo. What also ends up happening is that some patients just don't send their photo in until right before the visit. And of course, these are 15-minute encounters. So you go into the visit and you open the photo and you realize that you're dealing with a photo that you can't even make any assessment of. And then the entire visit becomes about how can you take a better photo than the one you sent in, that instead of the actual clinical visit, and you fall behind. So this wastes everyone's time. It wastes the clinician's time. It wastes the patient's time. So we thought, all right, well, online check deposit's so easy now. You take your check, and you take a photo of it and it's clear and it's crisp. What if we could build an algorithm that would help patients so that they could take good photos of their lesions so that we wouldn't waste so much of their time and our time dealing with this poor photo quality? We call this algorithm Truelmage. And so the idea is that the patient would take a photo, it would give them feedback based on the issue, and then the patient would hopefully resolve that issue, take another photo, and then the algorithm would tell them, okay, this is a good photo. You can go ahead and send this image in. And as I mentioned before, one thing that we've been very cognizant about is trying to be inclusive of diverse skin tones. So we actually went and specifically identified skin of color photos that we could bring into our data set. And with our labeling, we always label images not only with the photo quality data, but also like skin tone data, so that we can make sure that our algorithm is fair. And so our first proof of concept pulled images from multiple different sources and multiple different clinical data sets. And I say greater than 1K because I actually get photo dumps of several hundred photos every week. And we basically update the algorithm on a regular basis. So whatever I'm showing you today is actually probably obsolete by now because we are basically constantly doing updates on this. So we initially had started out with a smaller data set. And so we've actually published the first iteration of the algorithm in this paper. The second iteration now is a little bit more complicated, but the initial iteration was just using a logistic classifier with these different features, basically looking at the pixels and making an assessment of the contrast of the pixels and whether it looked like there were more skin pixels in an image, like it's too zoomed in or it's too zoomed out. And it pulled in some segmentation of the skin and lesion in order to be able to assess the features, because obviously we don't care about what the background looks like. The new iteration of the algorithm is actually an ensemble of that initial logistic classifier and a deep learning model. And it actually has had a huge boost in its performance since then. And so basically we show, based on where you want to set your threshold, that Trueimage can help you weed out the poor quality photos. So with good and bad, we can actually weed out about 90% of the poor quality photos while keeping 50% of the good quality photos. And what that really just means for the patient is that they would have to just snap a second photo. So we are working on improving this so that we can keep more of the good quality photos. But the good thing is that it only takes a few seconds to take another photo. And so if we sort of lose out some of the good quality ones and have them retake, we are okay with that. So it doesn't have to work perfectly, but the place where there's a lot of pain is with those poor quality photos. So if we can weed out as many of those as possible, we end up saving both patient and clinicians a lot of time. And then, of course, that's the first, like whether it's good or bad. And then we're basically working on making assessments on being able to give feedback and say this image is too blurry so that they know that they need to focus, or this image needs to be under better lighting. To be honest, a majority of images are blurry. Blur is one of the biggest issues. I would say lighting is the second biggest issues, and many of the images have both, and the algorithm can catch whether both is an issue, and so it will give that feedback to the patient. Now, eventually, our high level goal is actually to get to the point where, you know, like when you do your check deposit, you don't actually have to take the photo, that we can make adjustments and automatically take the photo. But as this first iteration, we're just giving patients feedback and asking them to retake the photo in order to collect more information and improve the algorithm. And actually, we're going to be implementing this in a clinical trial to assess how it actually works in patient hands, because right now we've been actually just using retrospective telemedicine data. We're actually going to start with that clinical trial this summer and have some funding from Stanford to do that, because there's significant interest in being able to build something that we can integrate into their My Health system, which is the system they use for patients to send in images. So right now with the algorithm, we are collecting additional data. And as I mentioned, we are getting ready to deploy this summer. And this is the Trueimage team. And it's been a very fun experience to do what I call bites to bedside. Essentially, we started development last summer, and a year later, we're working on looking at some early clinical trials to see how this thing actually works in the real world. And I would be happy to take any questions anybody has at this point.
All right, Roxana, thank you so much for this kind of whirlwind presentation of many different projects. I know that it usually takes people a few moments to kind of gather their thoughts and warm up for questions. Well, I do see one in the chat now, and it looks like I think one of the questions was, how camera dependent are dermatology models? Because you mentioned that, you know, with Trueimage and with other things that you're describing, there is such heterogeneity. Is most of that heterogeneity in terms of the quality of the actual photo taken, or how do models kind of think about, you know, like you're saying, this is an iPhone, this is an Android, or this is, I might have used essentially a flip phone from 10 years ago?
I don't think flip phones could take photos back then, right? But so there's one paper, and I don't remember the quantified drop in performance. There's one paper that shows a drop in performance if you train purely on iPhone photos and then switch to Android photos, or purely on Android photos and switch. So there is, we know that there is some differences, and it's hard to quantify what that is, right? Because as I mentioned, each digital camera has like a different proprietary color balancing. So it could be any of these things there. I think the answer here is to just, one, if you can document that metadata for images, which is something that is not always a reality. Like, for example, with Truelmage, we don't have that since they're patient submitted photos. We don't always have, what was used to capture the image. Is to, if you can, first document the modality so that you can look at whether or not that that metadata leads to differences in performance, right? So that's like the ideal setting, because then you can actually like assess it. But if you can't do that, then you should try to be as multimodal as possible to hopefully make sure that none of the imaging modalities become sort of out of distribution, as in the algorithm's like never seen it. And you kind of then hope that by having multiple image capturing modalities, it will realize that, that's not something that it should use in its discrimination between, lesions for whatever task. So at least because this is a whole debate, right? Debate one is like, oh, because there is a DICOM standards group in dermatology, as a working group. They've even put out a paper a couple years ago.
There's DICOM for dermatology.
There is a working group. It's not applied. So there was a working group that put out a paper like maybe 2-3 years ago with all these recommendations for DICOM standards for image capture in clinic, with like standardized lighting and all this stuff. And this is like a discussion that I have with my collaborators all the time. Like, you could create a standardized, image capture and take those photos and build a model around that. But the problem is, real world clinical practice of dermatology doesn't follow those standards. And so even you would only be able to build an algorithm that would only be able to work in those ideal situations. And so in my mind, you have to work with what the actual real world clinical workflow is, which is having this like very heterogeneous data. So I feel like you have to just train on the heterogeneous data that is representative of what's actually seen in clinic. And that's kind of what we've done with Trueimage right now, where we had some images we scraped from the internet. We had some images that we generated on different cell phones, like ourselves. We have images coming from Stanford. Eventually we want to get images from other sites, because we want to have something that's like actually assessing, the way that images look in the real world, and not these idealized perfect images. I, personally feel that dermatology isn't ever gonna move towards like implementing those DICOM standards, because lighting conditions are different in every clinic. Like, some clinics have natural light, some clinics don't. Like, technology is going to change. If you only train your algorithm on like iPhone 10 photos and then like you get to iPhone 15, right? Like, that's going to be a problem. So I feel like that model, unfortunately, of standardized photography is going to be a little bit harder in derm, except for the circumstances of maybe like 2D Canfield 2D imaging, which is this large like whole body 2D imaging. Like, sure, you could build algorithms around that one particular imaging modality or technology, but even that's going to update with time. And that's only available in like certain academic centers. But it's just making sure that people are aware and cognizant of this issue, so that, they take it into consideration when they're designing their algorithms.
And this was my first time hearing you describe your work with IBM. As I was thinking about kind of how to approach some of the questions that you're thinking about, how, like, in terms of identifying, say, the skin tone automatically, one thing that you were mentioning is like identifying where is healthy or not healthy skin. Example, I guess, like with vitiligo, it'll look like a very different skin, I guess, kind of classification if you chose a different group. Can you tell us a little bit about like how do you identify, or what was the workflow to even label data as this is healthy skin, this is not healthy skin?
So, I mean, obviously dermatologists were involved, and it was just drawing many segmentation masks. Some were available actually already on lighter skin tones. So they trained on that. What was actually really missing was the darker skin tones. And that's sort of where I came in and pulled many images of darker skin tones, including vitiligo, to show that the depigmented part was technically, diseased skin. So of course and I think I'll tell you right now, you saw that the performance isn't perfect. And some of those performance drops are directly actually from that issue. The skin segmentation is the issue, right? Like identifying the ITAs is not, not the hard part. It's really the segmenting out the area. And segmenting skin in general is not as hard because people have been working on that for a longer part, but segmenting out the healthy skin, particularly in darker skin tones where there's not as much data. And so I've been working on basically generating that data to improve the performance. The nice thing is like we're working in a space where we don't have to be perfect, right? Because no patients will be harmed from that, but we need to get it as close as we can to the ground truth as possible. Because we basically, if we're within a few percentage points of the ground truth, that will generate, that will show whether or not there's bias, because both 10%, darker skin tones and 13% darker skin tones in a textbook that's, I believe several thousand pages long is bias either way. So one of the nice things with the tasks, I mean, this was kind of by design due to some of the limitations that we have in derm. Work on tasks where, improvement, it doesn't need to be perfect for things to improve significantly and to help clinicians with their task. And then we can continue to like work towards being more and more perfect, but patients will not be harmed in any way.
Can I ask one question?
Go ahead, Pio.
So it is excellent presentation. I work here at Cedars-Sinai with medical images with cardiac images, so very different than the dermatology. But I wanted to go back to your first questions about this prospective studies versus retrospective studies in FDA. And we've been recently preparing a publication about the guidelines for medical imaging for the kind of things we do. And I have a hard time understanding why we would need a prospective study. I could see maybe in your application, I don't know, but let's say we work with outcomes and we have retrospective data. And I fully, first of all, I fully think this external validation is key, that you actually applied in other hospitals. But then if you have data, let's say from 10, 20 centers, you really cover every possible, possible variation in populations, hopefully. How is it going to help you then to prospectively try in yet another center? Why not just take external center and say how that works? Because in this retrospective studies, you do have all the outcomes, you don't know what happened with the patients, or you could even reread the scans, old scans retrospective, you can read them again, physicians can read them, for example. So I have a hard time understanding the prospective when it's not actually a device which is used during surgery or something, because obviously then you have to use it and see. But if it's like a diagnostic device, so we had this discussion, we couldn't figure out why we would need that.
Yeah. I think that's an excellent point, and I appreciate the opportunity to introduce some nuance into it. I feel in derm, I would like to see some prospective work, particularly because there's a lot of things that are not standardized, right? And because a lot of things happen in clinic that is different from just looking at an image versus radiology or cardiac imaging. The image is the workflow, right? And so like you were saying, you just have a radiologist reread it, looking with the tool. You could design something that's not truly prospective, but very closely mimics the workflow in order to make sure that there's nothing behavioral. For example, if something is meant to be used as a decision support and you find that clinicians are too often relying on it as a crutch instead of truly, using it as decision support. There may be things that you find from doing a trial where you are watching the clinicians use that tool in its intended use setting, which is exactly what I think you were saying with radiology. You can mimic the intended use setting with retrospective data, right? It's a little bit harder to do that in dermatology with the way that our workflows are. So I agree with your point that there is nuance there, and there may be situations where you can design trials using retrospective data across, as you were saying, multiple centers that would give you good data about how clinicians behave with that AI tool in a way that essentially recapitulates what they would be doing, reading that image. And then you also have like the read from before. So I totally agree with your point. I was kind of thinking of it more in the like dermatological realm when I was presenting.
Thank
that.
you. I guess great presentation though. Very interesting.
One thing I can think of that still might be a challenge with retrospective data is that I think that with retrospective data, it's much easier to cherry pick in terms of, we don't necessarily, at least kind of in many papers, don't fully really describe the inclusion exclusion criteria. So it's relatively easy to create a data set that can be arbitrarily easy. It could be purely normals and very abnormal.
Yeah. And
then the performance would look fantastic there, but maybe not directly represent the clinical application in a prospective manner.
Yeah, I mean, for sure. But the idea is if you have all comers in retrospective study, then obviously I'm sure you can also do something with prospective trials.
Yeah, I was gonna say.
The idea is to have just to be able to do something with the data you have, right? Like properly.
Yeah, I was gonna say, David, that prospective clinical trials also can make their inclusion and exclusion criteria such that they pick out the patients, and that's why whenever you read a clinical trial and then you have the medicine come to mass market, like the efficacy inevitably drops, right? But I think that's an excellent point that David and I think we also mentioned in this FDA paper, like if you have the retrospective data even in, and you look at it and you peek at it and you do anything, even if you don't fine tune on the retrospective data that you're planning to use to evaluate it, like, okay, I didn't fine tune on it, but I peeked at it and I know some things about its characteristics. That's technically data leakage, right? Even if it's not like overt data leakage. And I think that's one of the concerns that David is presenting. But like, as David also, as has been mentioned, there are ways also to cheat in prospective trials as well. And I think one thing that was brought up is like and I was involved in some of the papers that was talking about, guidelines for clinical trials with AI tools in dermatology. And basically one of the things that was very important is like define your inclusion and exclusion criteria very clearly and stick to them. So I think if you do that in a retrospective manner, and you don't do any of the things to sort of like cheat and know something about the data distributions ahead of time, then that is one thing. But again, I think the reason that people make these sweeping generalizations is that there's a lot of nuance when it comes to like what the task is that we're testing. And there are certain tasks, like for example, Google allowing patients to like assess whether or not they have skin cancer with this like app that hasn't been like prospectively tested at all. So we don't even know how patients are going to behave with it. Like that, it's like, I don't want retrospective testing. I want to know prospectively, like how do patients actually end up behaving with this application? Do they defer care? Are there times that like the app is wrong and the patient ends up deferring care and having more like advanced disease on presentation because the app was wrong, right? So like there's certain cases where it's like, I really would like prospective testing, but I think it's very nuanced and it's like harder to like publish those nuances in paper, in guidelines and papers, but I think we have to talk about them.
All right, so I think we are at the hour. Roxana, thank you so much for this very kind of comprehensive talk of essentially